I'll get started with introductions and then we can get cracking. So good evening, everyone. Thanks for joining us for our sixth Sunday supper, which is on the pelvis this evening. Once again, thanks for all our speakers for giving up their Sunday evening. I know things are starting to get a bit more busy now, so it's a great privilege that we can still deliver these sessions. A couple of quick announcements. So we've still got spaces for our virtual congress, which is happening in just over a week. The content is looking absolutely fab, and it'll all be available online for up to 2 weeks afterwards. So if you want to register, please do do so. All the information is on our website. We've still got spaces for our pre-congress Viva and ST3 bootcamp courses, as well as on our medical student day. For those of you who know any budding medical students who want to be to get some more information about orthopaedics. And we've still got spaces, or still looking for people to run for AGM. All of the information is on our website, but if you'd like to get involved with BOTA and be part of the committee, then please do apply. Standard housekeeping stuff. If you've got any questions, please do ask in the Q&A box and we'll field them at the end of each talk. And if you can make sure you do your feedback at the end of the session, that would be great. So without further ado, I'll hand you over to Chris, who's going to introduce our first speaker.
Yeah, so I'll introduce our first speaker tonight, who's Paul Harwood. So Mr. Harwood's an MTC consultant, Leeds General Infirmary, and specialises in major trauma with a subspecialty of lower limb reconstructive surgery. He's currently the Deputy TBD for North Yorkshire, has a Master's in Biomedical Engineering and a PG Certificate in Medical Education. He's got an extensive academic background, including trauma physiology, which is going to deliver an excellent talk to us today, and I'll hand over to Mr. Harwood. Who hopefully will unmute himself and we can hear his pearls of wisdom.
There we go. Am I on?
Yeah, perfect.
Okay, thanks for that. So thanks very much for the opportunity to speak. You've done the introduction for me. I've actually a lot of my academic work I've done previously has been about damage control and trauma physiology. And I've actually just submitted a PhD by publication on the topic. So I have some knowledge of it as a sort of trauma academic. It's a vast topic. And so what I'm going to introduce to you here really is a framework and some concepts. And this is part of a larger talk that I've sort of chopped down to do this. So it may feel a little bit stilted and it may feel a little bit like things are missing, and that's because they are, to fit it in the 15 minutes. But I've asked Chris if he can supply some papers, which I'll show actually at the end, and they're both open access, which summarize this aspects of this that are important for the exam quite well. So if you want that further information, it should be available to you there. So I'm going to talk about shock and host response to trauma. So I think there's some important concepts to introduce, which hopefully will be familiar to you from your sort of earlier training, and it's sort of, it's a standard MRCS type question in that what is shock? So shock is inadequate tissue perfusion due to inadequate or inappropriate circulation is the definition that I use, but you can make your own, but make sure you have one for the exam because it's something I have heard asked. And think about, this is again almost a medical student level question, but what types of shock do we have? So there's a list. And really what we're talking about here is hypovolemic shock, but of course you can have in multiply injured or severely injured patients other forms of shock contributing to their sort of altered physiology that we see as they present. So it's worth bearing those in mind if the patient doesn't respond in the way that you would imagine they should to your resuscitative efforts. I'm going to talk a little bit now, really, or the main talk actually, to be fair, about shock pathophysiology. So when a person suffers tissue injury and blood loss, this activates various homeostatic mechanisms, and they're a normal response and a sort of evolved response in a subject to try and preserve the blood supply to their critical organs and keep them alive, potentially at the expense of other the perfusion to other less critical tissues. So really that's the response that we see where the patient becomes peripherally shut down and they selectively perfuse their vital organs and stop perfusing other tissues in their body to maintain that perfusion, because otherwise the patient will die, and therefore the body is trying to balance that perfusion. We have to bear in mind that that means that if tissue oxygen delivery to a tissue is insufficient, anaerobic metabolism will occur, and toxic metabolites will accumulate, including lactic acid, various inorganic phosphates, and free radicals. Tissue injury, both direct and subsequent to this altered perfusion, release various cellular fragments. So these are known as damage associated molecular patterns, or DAMPs, or alarmins, and these seem to have a critical role in activating an inflammatory response within the patient. So that leads to appropriate local and then probably inappropriate systemic inflammation. And we'll come on to all of this in a bit more detail to try and give you a sort of framework to hang this sort of concept on. The vascular endothelium becomes damaged as an endpoint in a lot of these pathophysiological responses, and we'll see why that's a problem for patients shortly. As the ATP supplies become exhausted in a patient with hypoperfused tissues, the cellular homeostatic mechanisms fail and the cells die. And this ongoing tissue damage, both direct and indirect due to these mechanisms, leads to organ failure. And those become detrimental to the homeostatic mechanisms of the whole person. And in extremes, so where this reaches a sort of rapid endpoint, the myocardium and the cerebrum fail, and that results in very rapid patient demise. So what we're going to talk about now, that to put that into some sort of context, and this is the sort of thing people get asked about in the exam, is the lethal triad, which I hope you will have come across before. And these are three sort of aspects of a patient's response to injury which are particularly injurious to that person, those being hypothermia, acidosis, and coagulopathy. We see these very commonly in combination in badly injured people. And if you think about why that might happen, so people get cold because of environmental exposure, you get changes in the circulation, as we already described, blood loss, which doesn't help their situation. There is an iatrogenic component to this, so people get cold because we don't keep them warm or warm them up. But also, if you think of some of the interventions, if people are having their abdominal viscera exposed, or they're being washed or in theatre with cold fluids, or they're being given non-warmed resuscitative fluids, that can cool them down. And then there is a loss of homeostatic control for the reasons we've described, which may contribute to that. Similarly, they become acidotic, get anaerobic metabolism and lactic acidosis that we've already discussed, cellular and tissue dysfunction, again, loss of homeostatic control. And then the patients become coagulopathic. There's consumption of the components of the coagulation cascade, you get fibrinolysis, clotting product dysfunction, a dilutional effect from resuscitation, and again, loss of homeostatic control. And what we have to bear in mind is these three things drive each other, and therefore this becomes a rapid cycle of worsening pathophysiology, leading ultimately to patient demise unless it's stopped or prevented. And we've got to also bear in mind that ongoing blood loss, tissue hypoxia, and ongoing release of toxic metabolites will drive this even further and even faster. So this is to put this in a sort of diagrammatic form, which some people, or I find it easier to understand. So you get these sort of components that we've already described. They all come together to drive this lethal triad, which is a self-perpetuating, self-amplifying problem. And those things all put together contribute to further organ dysfunction and further bleeding, which drive these things on the outside to make all of it worse. So you've got two cycles going on at once, all of which are driving each other. And this is why this is such a dangerous position for a patient to get into. And it's much better to prevent it happening than to try and reverse it, which can often be impossible. And that's sadly often the result if that isn't stopped. Alongside that is the concept of the systemic inflammatory response, which is more an ongoing response. What we've talked about already is the response to massive hypovolemic shock. This is something that the systemic inflammatory response is what sort of follows on from that. And again, I'll put that into a conceptual framework to sort of something to hang your hat on if you're asked about this. So you may have heard of the two-hit hypothesis of a systemic inflammatory response. You have a period of systemic inflammation which primes the patient, and a secondary insult which can result in an overwhelming systemic inflammatory response. And there may also be a period of rebound depressed immune function when the patient becomes more susceptible to infection. So if you think about the mechanisms which underlie that, patient suffers an injury and has appropriate immune or local immune activation. As part of that, various inflammatory mediators are released into the local tissue, which increase and amplify that immune activation. But where that increases to a point where it escapes local control mechanisms, you get spillover of those mediators into the systemic circulation, which may be inappropriate. If we get inappropriate systemic immune activation, this itself drives the process further with more mediator release. Again, there is as we've already mentioned, this tends to result in, amongst lots of other things, increased vascular permeability. There is then extravasation of activated immune cells into the patient's own tissues and tissue injury by the patient's own immune system. So this is like a acute autoimmune type response. And that leads to further injury and immune activation. If we think about that as a time scale, so if we think time versus some measure of immune activation and the patient is injured, this is a sort of diagrammatic representation. The patient mounts an immune response. There is then a compensatory anti-inflammatory response. And where that is balanced and controlled, the two things nullify each other. And this is then an appropriate response to that injury. Where that gets out of hand can be where there's what's been termed a second hit. So there's this immune activation and then a very severe second response, which can overwhelm the patient. There's then anti-inflammatory activation, which again becomes excessive and deleterious to the patient. So here we have what have traditionally been called the SIRS and CARS, which CARS is the compensatory anti-inflammatory response syndrome, where the patient can be more susceptible to infection, etc. Actually, if we look at what really happens in a patient and a modern representation of this, it probably looks more like this. So you get this overwhelming response and then simultaneous inappropriate disordered activation of both parts of the immune system, those being the pro and anti-inflammatory, in an uncontrolled manner, so the patient cannot fight infection. You get aspects of both simultaneously occurring. There is probably a genetic predisposition to this because this response is not universal. Two patients with immune equivalent injuries may well respond very differently. And there is likely a genetic predisposition to this response, which sort of research into this is ongoing. I'm going to give you a really quick touch on what the rationale for early fracture stabilisation is, because again, I think this is important for clinical practice and the exam. To give a historic perspective, it was shown very early on that early stabilisation of long bone fractures reduces morbidity and mortality. Splinting of femoral fractures in the First World War, was shown to reduce mortality from somewhere around 8% to 20% on the battlefield. There was a period in the 70s and 80s, however, where multiply injured patients were felt too unstable for surgical stabilisation of their long bone fractures, and lots of patients succumb to a multi-organ dysfunction type syndrome, recognised as a fat embolism. Then in the 80s, we had this era of early total care with early stabilisation and aggressive resuscitation in the first 24 hours. And there are multiple cohort studies which have been shown which have shown improved outcome with this approach. And these are just a couple. So here you see early stabilisation of femoral shaft fractures in multiply injured patients with a 5-fold decrease in ARDS if done within the first 24 hours in the multiply injured group. And a similar study where early stabilisation of long bone fractures reduced pulmonary complications, length of stay overall, and length of stay in ICU in the group with, again, in those who were multiply injured. There then came this period of time in the 90s where this dogma was questioned, because in the most severely injured, so whilst the whole group badly injured people seemed to benefit from this, in the very severe end of that group, there was a poor outcome with a group of fully skeletally reconstructed dead patients in the morgue, and people who were working in big centres where they saw large numbers of these patients began to adopt a more selective approach. And this brings in the concept of damage control, which again, I cannot cover in detail here, but I'm going to touch on finally to give you an awareness of this, which I hope, to be honest, most of you will already have. Damage control is a concept that comes from the American military in naval, the naval sphere. This is the idea that if you have a damaged vessel at sea in a battlefield, rather than trying to repair it completely out at sea where it's still at risk of further attack, you patch it up well enough so it can get back to port and get repaired properly so it can live on to fight another day. The idea in patients is that you have an initial approach to trauma management aimed to prevent or arrest these self-perpetuating pathophysiological processes, which you've already heard about. And this is a specific approach to resuscitation. And in very severely injured patients, surgical treatment only of life and limb threatening trauma in the initial phase. There is then a rapid return of the patients to critical care facilities to support and correct abnormalities in their physiology, and their definitive treatment is delayed until their immune dysfunction has passed and been corrected, and the patient is able to cope with that burden of surgery. The concept of damage control resuscitation, I will not go into in any detail, but there are 5 real main pillars for that, which are permissive hypotension or initial restricted fluid administration, hemostatic resuscitation, which I hope you're all familiar with major hemorrhage protocols, which have been adopted pretty much across the board now, rewarming or the prevention of hypothermia, early hemorrhage control, and the correction of acidosis by resuscitation rather than by chemical means. And then finally, the concept of damage control orthopaedics is in the most severely injured patients, use minimally invasive techniques where at all possible, avoid prolonged and complex reconstructive procedures in the early phase. Long bone stabilisation is still very important, and this concept that a patient's too sick to have anything done is probably or almost certainly always incorrect. Intramedullary instrumentation appears to be particularly problematic, and therefore often spanning external fixation is used. Here are a couple of papers which I think will cover a lot of this, and so there's this great paper that I found really useful from the group in Nottingham, from Chris Moran, which talks, it's in the JBJS, or then JBJS, now the BJJ, which you should be able to get, all of you should be able to get. And I think it's beyond the point now where it's restricted, even if you don't have a subscription. And the damage control resuscitation, disclaimer, this is something I wrote with one of our trainees, but this just gives a sort of overview of the concepts of damage control resuscitation if you've not come across it. And there's more than enough information in those 2 articles, I think, to give you something to hang your hat on for exam questions on this topic. So very briefly to summarise, I think it's important for the exam and for clinical practice that you all understand the conceptual framework for a host pathophysiological response to major trauma. And think about damage control, which I haven't talked about in any great detail here today. I think to summarize that, we all use by sort of default damage control approaches in the very severely injured patients. We have to consider damage control for this borderline group of patients, which we haven't defined today, but these patients who may initially respond but have physiological or anatomic patterns to their injuries which make them at high risk. But as you'll see, we're now entering a new phase of what's been called early appropriate care, where with early aggressive resuscitation using a damage control approach, we can render these patients back to some form of physiologic normality very quickly. And then, even in the most severely injured, early total care, that being early skeletal reconstruction as appropriate, may be to their benefit, shall we say. Okay, that's me done.
Great, thank you so much, Mr. Harwood. We've not got any questions at the moment, so in the interest of time, I think we'll probably just crack on with our next speaker, but if anyone does have any questions, if they could just type them in the Q&A box. Mr. Harwood's going to hang around for a little bit, and he'll type some answers in the next couple of minutes, but if not, we'll just crack on. So our next speaker is Mr. Tim White, which I'm sure many of you will know the name. He's a consultant orthopaedic trauma surgeon in Edinburgh and director of trauma and orthopaedics. He runs the Edinburgh Trauma course, Trauma Symposium, and he's also one of the authors for the best-selling Rockwood and Green. He's committed several chapters to Rockwood and Green and the best-selling author of McRae's Orthopaedic Trauma. Better get that the right way around. And he's going to talk to you about pelvic fractures.
Okay, I hope that is working. Can you see my screen and see my slides there?
Yep, all good.
All good. Okay. Right. Good evening, everyone. 15 minutes covering all the essential elements of pelvic trauma, really following on from that lovely description of the stress response to trauma, and looking at really some of the ways that we can try and avoid that stress response. So we must know a little bit about the anatomy of the pelvic ring. The two inanimate bones are stabilized at the front by the pubic symphysis, and then at the back by the sacrotuberous and sacroiliac ligaments, by the anterior sacroiliac ligaments, and then at the back by the posterior sacroiliac ligaments and the lumbar fascia. And these soft tissue connections between the two inanimate bones are absolutely crucial, and we'll be referring to those later as we go through the talk. Now, the structure of the pelvic ring in terms of its stability is crucial, but of course, the other important consideration is the pelvic floor itself. And this is where we tend to meet some of the more severe long-term problems in terms of continence and genitourinary and sexual function. We'll speak briefly about radiographic views. Classically, these consist of an AP and inlet and outlet views, which are rarely obtained in the emergency department, but are useful because I tend to construct these views in reformatting the trauma CT. And they're also extremely useful intraoperatively in guiding placement of metalwork. So if we take the patient lying supine, an outlet view is obtained at 45 degrees to the pelvic ring and gives a very good picture of the sacrum en face with the symphysis pubis almost overlying the lower part of the sacrum. In distinction, the inlet view is taken 45 degrees cranially, and this provides that sort of beautiful round view that shows you the pelvic ring and gives you a very good indication of any disruption of the anatomy of that ring. That then brings us neatly on to the classification of pelvic fractures. There are two different classification systems that are well worth knowing about. There's a Young and Burgess, and then the Tile or AO group. Young and Burgess neatly divides these fractures into three groups: the anterior posterior compression or open book fractures, the lateral compression or the vertical shear, and then there is a fourth group of combined mechanism or unclassifiable fractures, which always make up a small proportion of those presenting. The Tile classification aims really to shoehorn this Young and Burgess classification into the standard AO, A, B, and C. And you can see that apart from the Tile A classification, which are those not involving stability of the pelvic ring, the B and C classifications really are components of the Young and Burgess. So if we just deal with the type Tile A, fractures not involving the pelvic ring, these are very simpler ones that do not have any significant disruption of the ring, and they're relatively stable, but do tend to cause pain and on occasion instability. So here's a patient who's become spatchocked by a wooden fence post, resulting in some injury to the ilium, which then requires to be reduced and fixed and stabilized. But you'll see that the pelvic ring itself has not been disrupted. So that's a Tile A. Moving on to the Young and Burgess, which is actually rather more intuitive and rather more useful. This is a picture of Anthony Burgess, who is still alive and well. And I spoke to him at one of the Orthopaedic Trauma Association meetings relatively recently and asked him about his classification system. And he described how it was put together. And after a trauma meeting in their hospital, a few of them went down to the pub, and in the course of 20 minutes on the back of a beer mat, they managed to throw out this system, which has remained amazingly useful and influential ever since. So let's go through these parts one by one. So starting off with the APC, anterior-posterior compression, one hemipelvis is pulled off to the side, and you can see progressive disruption of the anterior and then posterior soft tissue structures. These APC injuries are associated with major hemorrhage, particularly from the low pressure presacral plexus of veins at the back of the pelvis. And you can see how easy it would be to disrupt the pelvic floor, and therefore urethral and bladder injuries are common. And the management of these is to close and stabilize the book. APC injuries are divided into three subtypes. The first two, depending on how widely apart the pubic bones have been pulled apart. And APC3 is a complete posterior disruption where the hemipelvis has been completely detached from the rest of the skeleton. So So that brings us on to lateral compression injuries. These commonly occur from following a blow from the side and involve internal rotation of the hemipelvis. And then if the deformity continues, there is then an external rotation or an APC type deformity of the contralateral hemipelvis, as you can see in this short animation just here. So because these generally occur as a result of a collision or an impact from the side, the important associated injuries are not those of the APC fracture, they are of associated injuries to the head, the thorax, and the intra-abdominal contents, as you can see here. Just as for the APC injuries, these lateral compression injuries are subdivided. The least severe is the LC1, the pubic rami fracture. Moving up, the LC2 also has an injury posteriorly, and classically, this comprises a crescent fracture, where a small crescenteric fragment of the ilium fractures off and remains attached to the sacrum, and we'll see an example of that later. And then the LC3 is a windswept pelvis, where one side is internally rotated and the other is externally rotated. Finally, the vertical shear pattern occurs when one hemipelvis is raised in comparison to the rest of the pelvic ring. And as you will not be surprised to hear, it results from a vertical force. And these injuries are both rotationally and vertically unstable, and all potential injuries are possible. So these major pelvic hemorrhages from the internal pelvic plexus, the larger vascular arterial anatomy, and also the head, chest, and intra-abdominal contents are all at risk. So terrible, severe injuries. These are also subtyped. Yes, one unilateral, and then the two are bilateral. And so in summary, you'll have noted that this classification system is extremely useful in predicting where the injury is going to be and what the likely cause of the patient's death is. And that helps to focus our management. Quick word on urological and neurological injuries. Urological injury is indicated by blood at the meatus, swelling of the scrotum and perineum, and can be diagnosed more clearly by a retrograde cystourethrogram. Now, this can be performed before catheterization if there is clinical suspicion, but it is perfectly acceptable to attempt a single gentle go at passing a Foley catheter into the bladder. If this is not successful, stop and obtain a urology review, and this is subsequently likely to require a suprapubic catheter and then some form of urethral reconstruction. Neurological injury, on the other side, is not often diagnosed accurately at the time of presentation. It's not part of urgent fluid resuscitation. The patient is often unconscious and intubated, and it may not be until later that subtle abnormalities of the L5 and sacral nerve roots are diagnosed, albeit these are devastating when they do occur. So, immediate clinical management. Of course, these patients are managed according to the ATLS principles, of which you are all aware, and that will bring us a grid here of 4 potential situations with our patient with the pelvic fracture. So the patient may have a mechanically stable pelvis, like that tile A fracture we saw earlier, and the patient may be hemodynamically stable, in which case our treatment is going to be planned and carefully thought through. The patient may have a mechanically stable pelvis, but they may be hemodynamically unstable. In this situation, the cause of the problem is not the pelvis, and other sources of hemorrhage must be searched for. We then have a situation in which the pelvis can be mechanically unstable and really quite alarming on X-ray or CT, but in fact the patient themselves is hemodynamically stable, and in this case, again, treatment is planned. But finally, of course, we'll have the situation where the patient and their pelvis are both unstable. And then, of course, this is the group that we focus on particularly, both in terms of our thinking and in terms of the exam itself. So, in summary, we have to distinguish the hemodynamically stable patient with a major pelvic fracture from a hemodynamically unstable patient with a major pelvic fracture. Let's deal with the easier situation first, where the patient is hemodynamically stable. We're going to complete our primary, secondary, and tertiary surveys. We're going to look at the head, thorax, and abdomen. With specific regard to the pelvis, we're interested in skin viability. and skin integrity. And that's both externally and also internally. And the perineum, as well as the rectum and vagina, can all be sources of open or internally open fractures. We talked about a urological assessment and a neurological evaluation, if that's possible, followed by imaging of the pelvis. We're then going to consider removing the binder and then carrying out planned internal fixation. Okay, let's look at the other situation, the hemodynamically unstable patient. We approach this with our standard ATLS approach. We know about the sources of hemorrhage and the fact that they can be in these 5 locations shown in the picture here. We have to bear in mind the importance of the lethal triad that Mr. Harwood was describing to you earlier, and our major resuscitation protocol, bearing in mind the importance and the gradually developing profile of blood gases and of TEGs. But in the early stages, the algorithm is extremely simple. If you have a hypotensive patient with an unstable pelvis, apply a binder. Now, this is often done already for us by the ambulance crew on suspicion in the field before the patient arrives in the emergency department. We're aware that the pelvic binder splints the pelvis, and that stops movement, allowing clots to form and then remain without being dislodged and with the resultant hemorrhage. In the open book, fracture possibly also decreases pelvic volume, but I'm not certain that is as important as just stopping the pelvis from moving and clots being knocked off. In the lateral compression fracture, and indeed in acetabular fractures, it really probably does nothing very dramatic. It splints the bones, and most importantly, it does no further harm. And so for our emergency department colleagues, that simple linear algorithm can be applied to all pelvic fractures without them needing to know the complexities of the actual pelvic fracture type that they're seeing. Now, although these are often applied in the field, it is important that you know which type of pelvic binder you have in your own institution, and you need to know how it works. So go and have a look in your emergency department resuscitation room and look through the information sheet if you're not familiar with it, so that you can apply it without any delay. If there isn't a proprietary binder, then the use of a draw sheet is extremely useful. It's extremely quick, it's very cheap. The draw sheet can be fixed with Rampley's forceps, as you see here. And then actually it's also very useful for definitive management because you can cut holes in that draw sheet and do things like insert sacroiliac screws without having to remove the binder. So don't forget the humble draw sheet. The pelvic binder is just a resuscitation aid, and its use is during the resuscitation phase of the management of the pelvic fracture. And there is a downside. If you leave a pelvic binder in place for a prolonged period of time, and that is more than 6 to 8 hours, there will be skin compression and ischemia, and you may end up with either vulnerable skin or actually necrotic skin that then compromises your further management. So once the resuscitation phase of management is complete and the patient has lost its their lethal triad, we're going to take that binder off and perform a binder off X-ray. Then the patient's going to move on to laparotomy, angiography, or definitive pelvic stabilization. Angiography being helpful in the transient responder, but of course with a potential for taking out major sections of blood vessels, the soft tissue, with resulting ischemia and necrosis. Pelvic packing is a technique that you should be aware of, performed in theatre, usually in a patient who's going to be in theatre in any case. So definitive management in the anterior ring is an X-fix or a plate at the front, and at the back is sacroiliac screws or a plate. This is not something that you need to know about in detail. It's a complex procedure, often requiring interaction with the interventional radiologists and neurological surgeons. So I've just got time for a couple of cases. Just think to yourself what this would be. You'll have noticed that there is a pubic symphysis diastasis, more than 2.5 centimeters. It's an APC2. With a binder, it's closed, and the definitive treatment is anterior fixation with a plate. Second case, you'll have noticed, if you have a careful look at this X-ray and look to see where the problems are, you'll notice that there is a pubic ramus fracture at the front. There is an injury at the back with some sort of fracture through the ilium. And this is a crescent fracture indicative of an LC2 injury. And on a CT scan, this very typical transverse pubic ramus fracture is confirmed with an anterior sacral compression fracture at the back. And the CT reconstruction shows that crescent fracture, so indicative of an LC injury. And this is treated with a combination of fixation at front and back. So just finally then, here's an injury which is, you can see there's some internal rotation of one side. The CT scan confirms internal rotation of one side and external rotation of the other, leaving this to be a windswept or an LC3 pelvis. And this is treated with fixation at the back and then the use of an external fixator with pins in the supraacetabular region at the front. Last case, you'll see here, if you look carefully at the images, that on the right-hand side, there appears to be some vertical displacement of the hemipelvis. And that's confirmed on CT, on 3D, on the MPR reconstruction at the back of the pelvis. And this required fixation both at the back and at the front. So we've covered mechanical anatomy, classification, associated injuries, and management. George mentioned a couple of resources. I'd encourage you, if you want to have an overview of top to bottom of orthopedic trauma, to look at the Edinburgh International Trauma Symposium. That's our website, and that QR code will take us to the website. And then at some point, I downloaded my brain into this book with all my orthopedic trauma knowledge. And this is a resource that you may wish to consult during the course of your reading. Thank you very much.
Thank you very much, Mr. White, for a whistle-stop tour of pelvis fractures. I'm sure will be very useful for FRCS revision for myself and for others. And for those of you who haven't been on the trauma course and got McRae's book, I can say they're definitely worth the money. The McRae's has saved my life on a couple of occasions when on calls in the middle of the night trying to find out what I need to do. We've got no questions at the moment. Unfortunately, Oliver has had to shoot off for some internet issues, so we'll just move straight on to our next speaker. If anyone does have any questions for Mr. White and they'd like to ask them in the Q&A box, I'm sure we'll hang around for a couple of minutes to answer anything typed there. If not, we'll just move on. So our final speaker for this evening is Dr. Sedki. He's a consultant in rehabilitation medicine at the National Orthopaedic Hospital in Stanmore, and regularly lectures on prosthetics for the FRCS to the Stanmore revision courses. And he's going to give you a quick whistle-stop tour of prosthetics for the FRCS.
Hello, everyone. So I've been tasked to do this presentation this time for the first time as a very condensed one, really. And I'm trying to condense a whole specialty into just half an hour, but this is mainly for the purposes of an exam. So I think I have an idea about what your examiners might want, but I have to say that I've been doing this for the past maybe 10 years or so, and I haven't had any feedback to show whether the examiners were actually asking the things that we are talking about. So my focus now is just mainly to give you an idea about prosthetics. What is a prosthesis? What are the parts of a prosthesis? And how do you maybe get started talking about prosthetics in the exam? And even if you haven't seen a prosthesis before, maybe trying to make things up as you go. So I'll just start by trying to share my screen first. I hope this works. All right. Let me press play. Good. So to begin with, just a bit about terminology. As you can imagine, a prosthesis replaces a missing part of the body. I have always this confusion with orthotics, whereas an orthosis is something that supports an existing part of the body. So it needs to be something missing to call it a prosthesis, or at least partly missing. And it could be permanent, like your joint replacements, or it could be temporary, like our prosthetic limbs. We used to say rehabilitation for everyone, but nowadays, with people with congenital limb deficiencies, born without limbs, you're not rehabbing them back to anything that they were before, so we call it habilitation. Another shift in the terminology is the terms below the knee, above elbow, and so on. This is thinking of a joint in relation to a joint, and then you're going back to the amputation level. Now we say just transtibial, transhumeral, or through knee, through elbow, and so on. The stump, the term is not very popular with many of the amputees, as you can imagine, but we still cannot find a better term. The official term to use now, politically correct one this year, is residual limb, but it keeps changing all the time. I find this very confusing because I always think of the contralateral limb for that one. So you are still justified to call it the stump, and the stump is the remaining part of the limb up to the level of the most nearby joint, so the proximal joint up above it. Of course, I'm not going to lecture to orthopedic surgeons about what a prosthesis or a limb does, but there are lots of subtle functions of a human limb that you only notice after amputation. So you know, of course, about the top ones here with the movement and sensation and structure and so on. We've got here heat control. I've got many of my amputees, especially the ones who have bilateral or 3 limbs, 4 limbs amputated. They might come in the middle of the winter and they're wearing short sleeves and they are still overheating because you lose body surface area in relation to the body mass. The person now finds it hard to radiate the heat, and even if they sweat, also sweating does not help them to cool down a little bit. So heat retention becomes a problem. Blood pressure goes down usually because you have lost a lot of the arteries that were probably narrowed a little bit, especially if it's an older person or maybe a smoker and so on. And we have, of course, 80% of our amputees in the UK are vascular amputees who have either diabetes or just smoking issues and vascular insufficiency. These people usually require less blood pressure tablets and less medication in general after the amputation, because you've done almost like a liposuction also for the person. So if they were diabetic, you do not have as much insulin resistance after the amputation. So there are lots of other things that limbs do. It's just that the point here of this slide is that we're not replacing a human limb. A prosthesis can never, in our current technology, and probably for the next few hundred years, replace all these functions that a human limb can do. So we have to choose the functions we can replace, and usually the main important one is the mobility, or maybe for upper limbs is just doing certain tasks rather than all the tasks they used to be able to do. So this is just a bit of statistics, and it applies to most countries, I would say. So you can see a difference between the lower limbs and upper limbs. It's almost reversed. Lower limbs, we have 80% of the cases are vascular because of diabetes and smoking. Upper limbs, it's usually mostly traumatic and congenital deficiencies, people born without a limb. And then you have a small number of vasculars and so on. So upper limbs are the most common referral types, of course, to limb centers in the UK. And the most common level, unsurprisingly, is the below-knee or the transtibial amputation level. You have differences in terms of the centers in the UK. In England, there are about 34 centers. There are 43 or 44 in the whole of the UK, depending on how you count them. About 10 of these centers is called tertiary. Everyone likes to call themselves complex and tertiary, but actually, in reality, only 10 of them are mainly tertiary. And you can tell that a center is tertiary by having more traumatic cases, more tumors, more congenital deficiencies compared to the vascular cases which happen in more of the tertiary centers, more rural areas. Levels of amputation are well known, and you cannot just remove a limb at any level you want. Traumatic cases, of course, pose a challenge to the surgeon to create a very good stump that can take a prosthesis or be loaded with a prosthesis. The levels are mainly designed to allow the formation of a useful residual limb, but sometimes also to be able to have some function regardless of the person's ability. And this is mainly for disarticulations. So when you have a disarticulation, you can still use the end of the stump or the end of the residual limb for weight bearing or some weight bearing, because there's a cartilage covering that. This is a key slide, and I would love it if you can remember this for the long term, not only for the exam. So amputations are, as you probably already know, they are either transdiaphyseal or through a joint, and there are big differences. The two are completely different categories, and they behave completely differently. So these articulations, the main difference is that you have end weight bearing stumps. So you have cartilage at the end of the residual limb, which allows the person to put weight on it. This is a big deal. It makes a whole lot of a difference, both for the patient's quality of life, but also for the ease of manufacturing of prosthesis. Because on the other side, through the bone amputations or transdiaphyseal, the end of the bone is not weight tolerant. So the prosthetist will have to load the limb somewhere, and usually it is closer to the nearby joint. So in the transtibial level here, we are loading actually the PTB area, which is the patellar tendon bar area. That means the person is now holding to the door frames and not actually standing on the floor. So there's now shear forces, there's friction, And there's an abnormal way of loading the stump, while here we have almost a normal way of just loading the actual bone. And if you notice here also, we are bypassing the tibia with the load. The same applies to the femur. When we have a transfemoral amputation, we bypass the femur and we load the ischial tuberosity, which then also can tell you if a patient of yours comes and says, I've been using a prosthesis for all my life, and now I have pain in my hip joint on the same side of the prosthesis, it is unlikely to be very, let's say, very treatable arthritis that requires hip replacement, because you can still offload the joint. When they work with a prosthesis, they're not actually loading the joint if it was an amputation. If it's a disarticulation, so a through knee disarticulation user is going to load the femur or the hip joint. Another difference is the cosmetic outcome, because we have here a bulbosity at the end. Usually bones will have condyles at the end, and you have a bulbosity that dictates the whole width of the prosthesis. So it looks here like a cylinder. This is, of course, an ankle disarticulation level, what we call signs. And this is a common level of amputation. And usually ladies do not like it. They call it a cankle here, but also some men of my patients do not prefer this appearance. However, it's a very good level for somebody who wants to wake up at night and use the toilet, for example, prostate problems and so on. They don't have to wear a prosthesis to walk the few steps because they are end weight bearing, and they can forget about, they can just say, I'm okay with the appearance of it because I'm getting the advantage of other things. Here we have space down below, so there's more missing of the limb. Therefore, we can here camouflage it and make it look like an ankle. The space for components. So if you look here below the end of the residual limb, there's a lot of space. We could have, instead of the pylon here, we could have had a carbon fiber foot or a running leg and so on. So prosthetic feet, as we hopefully might be able to talk about quickly, are mainly springs. So the longer the spring, the more energy return you get from it. So when you have a spring that is very, very limited in height here, you'll have limited energy return. And famously for Symes levels, for example, these patients are unable to run, because in order to run, you need to fly for part of the gait cycle. Both legs need to be off the floor, and there's not going to be enough energy return from the prosthetic foot when we load it to allow the person to spring up and then push all the weight above the ground. The other foot will always be on the ground at some point. Suspension, we'll talk about this as well in a moment. Suspension is when we talk about attaching the leg to the person. So how to prevent the leg or the arm prosthesis from coming off the person. Usually these are self-suspending because of the shape of the condyles, so you can make it hold in place without adding silicone liners or cuff straps and things like that. While here we need to add something to it, otherwise it will slip down because it looks more conical in shape. The last point here is very, very important one to keep in mind. If you have a child and they have trauma, for example, you would want, if you can, to avoid doing an amputation. So of course, you sometimes have to, but if you can, you want to do a disarticulation. For congenital deficiencies, the default is to aim for a disarticulation, unless we have to do an amputation. I cannot think of many cases where we had to. The reason is that because of growth, if you do an amputation, the end of the bone will eventually tear through the myoplasty. There's no myoplasty that can grow with the bone. While here, because of the tendon attachments being natural onto the bone, the growth of the bone will just pull the soft tissue with it down, and it's not going to be prominent through the soft tissue. In an amputation through the bone, if you do an amputation on a child, let's say 5 years old, you are guaranteed to require 2 or 3 surgeries by the time they reach skeletal maturity to trim the growing end of the bone, because it goes through the muscle eventually. So if we can, we want to do a disarticulation of a child. So there's no better or worse between these two. It just depends on your patient. The ideal stump, I always get this question, and people always get bogged down with the length, because that's the obvious thing. The length is important, but it's not the most important. So the length of the stump, the answer in the exam could be still accepted probably when you say 12, 13 centimeters, but the better answer for a transtibial stump, because that's the most common level, is to say 8 centimeters for every meter of height. So it depends on how tall the person is, or you want 1 inch for every foot of height. We can work with an 8 centimeter stump. The shortest today with current technology of prosthetics is an 8 centimeter. And remember, prosthetists measure from the medial joint line, not like orthopedics from the tibial tuberosity. So we can tolerate even shorter stumps than you might imagine. 8 centimeters is very short from the medial joint line. But that's also, the shortest can be fitted. Doesn't mean it's going to give you a good result. The patient will be unhappy, they'll be in pain, they'll feel the leg is heavy and so on. For the transfemoral level, when you have the patient in theater, of course, you cannot see the hip joint. So there's no point of me saying, I want the length of the femur to be this and that. What we measure from is actually from the absent knee, because we want the clearance of the knee to be there. And these are the numbers. They are not exactly that now. We have more leeway even because of the new knee joints that are in the market, but this is the guidance that we want about 15 centimeters above the joint line, minimum 8 centimeters of the length of the femur, if you can measure it. Usually the effective length for a transfemoral prosthesis is measured below the ischial tuberosity. So although you normally measure the femur, but the effective one is from the level of ischial tuberosity downwards, because this is what will stop the prosthesis socket from being fitted properly on that bone. More importantly than the length is actually the myoplasty, the formation of the muscle and the end of the stump being beveled, the bones being in a good shape, fibula not being longer than the tibia or even the same length. We want it to be shorter because you want to position the tibia in the middle of the socket. And then the fibula will have to be shorter, otherwise it will be pushing the tibia towards one side, towards the medial side of the socket. And that's a very, very unforgivable mistake, I have to say, if the fibula is long, and we still see it quite a lot, unfortunately. Joints range of movement. So famous one, you go to see the patient post-operatively, and you ask for elevation. Let's elevate the leg because it's getting swollen. And they press the button, and the knee goes into flexion, and the hip goes into flexion because they're elevating like that. So you want to elevate it in a straight position, you want to keep the joints mobile. Try to get the patient to focus on mobilizing the joints as early as possible, prevent fixed flexion contractures. And of course, working on the scars. Scars always become adherent, and they keep shrinking inwards for the next few years after the amputation. They can cause lots of problems. Talking about prosthetic components. So this is also very relevant to the exam. First thing, the name of any prosthesis is the level of amputation. So you want to, when you get to the prosthesis in exam, you have to look at it and imagine what part of the limb goes into that one. So the giveaway here on this picture is the knee joint. Since there is a knee joint, this is then at transfemoral level because the patient has lost their knee. So whatever you see is absent in the patient. So the name of the prosthesis is the name of the level. So this is a transfemoral prosthesis. The components are usually these ones, but you can summarize them even into 3 components only. These are the main ones. We've got the socket at the top, and that's the main part that the prosthetist will have to train to make, and it takes them ages to get it right because it's not really an exact science. It's a black art, more or less, and there's a lot of leeway in it and lots of the person feeling and thinking, oh, this is how it should be, and rather than you cannot measure it. So this is still the hardest bit to make. So every prosthesis has a socket, and it could be that the whole prosthesis is a socket, like for example, a cosmetic hand prosthesis, which is made of silicone. Towards the end, we have what we call here the terminal device. Of course, this is a foot and a lower limb prosthesis. For another upper limb, it could be a screwdriver, it could be a hand, could be a hook, could be anything. So we call this a terminal device. And in the middle, we have a link. The link could be just a pylon. When you have a below knee or a transtibial prosthesis, that could be just a pylon there. Or it could include joints like this one, could include shock absorbers, rotators, and fancy things like that. But end of the day, this is the link. So top part is a socket, lower part is a terminal device, and there's a link. Every prosthesis most likely is going to be exactly these parts. Then you can add the other 2 here. So suspension is added to the socket, although it's not always part of the socket, is the way, as I said, to attach the leg to the person or the arm to the person. Cosmesis is used to be thought of as the cover we attach on top of it, but nowadays it's a concept. So in the next few slides, I'll just expand on each one of these items a little bit. So I know you like X-rays. This is just to show you how a comfortable prosthesis looks in an X-ray standing up. So this is the socket. And if you look at the X-ray, there are lots of gaps that the prosthetist had intentionally made in the socket. So first idea is that it's never an exact copy of the person's residual limb. If you make an exact copy, it's never going to be comfortable. Why? Because you don't have enough surface area in the stump to load the whole person's weight comfortably. Remember, when we're walking, we're hitting the ground with a heel strike. There is a moment of force which is going to be above our weight because there is deceleration. So there's a lot of force going into the legs when we walk, and if we distribute the forces evenly, then the sensitive areas, the bone ends, maybe the neuromas and the tender parts will become uncomfortable. Therefore, the prosthesis has to do this. They have to offload the sensitive areas, and they have to overload the pressure tolerant areas. And to do that, they have to know the map of the residual limb. So there are areas that are well defined, well known to all prosthetists, but also there are areas that are specific to the patient. So for example, somebody with a common peroneal nerve neuroma, so it will be somewhere between the tibia and the fibula at the end here, I will have to offload this area. So usually the prosthesist wants to load this because it has the peroneal muscles and it can tolerate some pressure, but I'll have to ask them to offload this. When they offload it, the weight has to go elsewhere. So they are overloading somewhere else. And you cannot offload everywhere. You have to take the load somewhere. So the prosthesis, by definition, is not going to be perfectly comfortable from day one because you are just putting weight, as I said, sideways on the wall door frames if it was an amputation. And the skin has to become tougher and build up the skin, like exactly when we break a new shoe. Probably a bit more hard though. This is how they make a socket. So a negative cast is taken. They just use the normal plaster of Paris that you're all familiar with. And you take a negative cast of the stump. Now, this negative cast is exactly the shape of the leg, but in a negative way. They take it to the workshop and they fill it with plaster. So now they have the shape of the residual limb in the workshop. They add a pylon onto that just for fixation on the table, and they have it there for them to work on. And now comes the most important stage in manufacturing a prosthesis, and this is where all the skill of the prosthesis comes in. It's called the rectification. So this prosthetist is now adding plaster onto the areas which he wants to offload, and he subtracts plaster from areas he wants to load or overload. So what he's doing is this. He examined the patient first, and he pressed on the several areas in the stump, and he remembers how much pressure he applied with his fingers before the person winced, before he started to say, oh, ouch, it's hurting now. And now they have to estimate how much plaster to add. So that's why it's a black art, and you cannot measure it. And that's why it takes a lot of experience. It takes a lot of these sockets to be made until the prosthetist really becomes good at it. And some people are better than others. There's also a talent and a skill. It's not all learned. Part of it is actually inherent in our brain, I find. And some prosthetists, you can see lots of even senior ones who cannot really still make a fantastically comfortable socket, or junior ones who just got the skill. You need to have a bit of understanding about how the person feels it, or your patient feels the leg. Once you're happy with the shape, then you take it to the technicians in the workshop, and they will just fabricate the socket. This is one way of fabricating. They call it lamination, where you've got a pump down below here. The residual limb, of course, here, the positive cast is upside down. It's already been rectified, and we have the resin poured from the top, and it just sets. It's like a plaster. So this is called polypropylene socket, one of the common types. It could be carbon fiber. It could be lots of different materials. You don't need to be bogged down with the material in the exam. One thing I find that orthopedic surgeons always try to say, is it a polypropylene? Is it polyurethane? Is it a carbon fiber? It doesn't matter really, because that's not the point. The difference between materials helps a little bit with the very high activity ones. But what you want to talk about is the actual level of the amputation. This is a transtibial, transfemoral socket, and where is the weight going to, and how is it suspended? So the socket is doing two things. It's taking the weight, loaded, or this is the stance phase in the gait cycle, and it's being suspended, or off the limb, and that's your swing phase during the gait cycle. Which leads me nicely to the suspension. Suspension is not like car suspension. As I said, it's not shock absorption. This is how to attach the prosthesis to the person. There are lots of ways of doing it, because none of them works perfectly, and you have to choose the appropriate one for your patient, and many patients change things as they change. Maybe their weight changes, or their needs change, or their mobility changes, and the suspension method changed. The one on the right, the cuff strap one, is the most commonly used one in the NHS for new amputees. The advantage here is that you can change, of course, the circumference as they shrink down, because the residual limb will be swollen. They shrink down, you can adapt it, and you can add socks on top of the residual limb here, because the interface also is flexible. It allows you a lot of error. It's not very accurate. But you wouldn't want to run with one of these, for example. This is a good one, like a slip-on prosthesis, let's call it, a good starter. And it used to be very popular before the liners and the silicone was invented, but now it has less indications, although you still see it quite often. The one on the left is an example of a very old school prosthesis, which we still also use. Type of it's called supracondylar, where you'll have supracondylar suspension. It works in the elbow usually and the knee in a person who is quite thin, and the bony condyles are prominent. So you make a socket that has some flexibility in the plastic, and it just goes above the condyles and locks onto them. Then the advantage here is, like, again, it's a slip-on prosthesis. You just put it on and get on with your day. You don't have to tighten things and just learn skills to put it on and off. And it's a nice one, again, for your prostate patient who wants to wake up at night and just put the leg on and walk to the toilet a few steps. The one in the middle is the one which requires silicone material. This came to the market probably in the 90s, became very popular very quickly because they allow the prosthetists to make lots of errors and get away with them sometimes. But what they do is absorb shear. This is the main function in my view. They absorb shear forces. They do that by gripping onto the skin. So when you have a silicone liner material onto the person's skin, it never slides. So you can never actually wear them like you wear a sock. You cannot pull them up the residual limb. They have to be rolled out first, and then you roll them onto the limb. And the old commercials for these things, they used to show the person suspended upside down from the silicone liner because you cannot shake them off. So it grips on the skin, and then it allows us any shear forces, sideways forces, to be absorbed within the layers of the liner. This one has a pin at the end of it, so this pin engages onto a lock in the socket, and then the prosthesis is secure and it's going to be well suspended until the person wants to take it off. They press a button and it's off again. This still allows a bit of movement, though. If you pull on the pin, soft tissues will elongate, allows a bit of movement, and this movement we call pistoning. The more pistoning the person has, the more uncomfortable it becomes, the more rubbing they will have, and the more heavy it will feel, because when it slides down, what they're doing is to lift the whole body weight to move forward. Therefore, they're feeling their own body weight. So we don't like pistoning. All of these systems allow pistoning. We cannot achieve zero pistoning unless we do osseointegration, as you can imagine, broaden the bone, but that's for another talk. Another method of suspension is suction, and you have 3 different ways here of doing it. This is very popular with more athletic people, more active people, because it allows the least degree of pistoning. It allows you not to have that much movement between the stump and the socket as they swing the leg. The one on the left here is a transfemoral socket. So you can now imagine, when you fill it with plaster cast, you can imagine the shape of the residual limb is a femur. It's not a tibia here. And we have at the back here the ischial weight bearing area, because the transfemoral sockets will always load them on the back, on the ischial tuberosity. There's no other place to load the socket. And that's another clue for you for the exam. You might be asked about that. So transfemoral, we load the IT area. Transtibial, we load the PTB area. There's a valve at the end of the socket, and the person will, when they put it on, we call it donning the prosthesis, D-O-N. When you don the prosthesis, when we take it off, you doff, D-O-F-F, doff the prosthesis. If you forget that, that's fine. It's just a fancy term, or it's a term that prosthetists use that might make you sound as if you've visited a prosthetic center and you know more about what you're talking about. So donning this prosthesis is on the skin directly. They don't wear any socks, and they just push the air out of the valve as they put it on. And here, the shape of the brim of the socket, the top part, it matches the groin, and that creates a seal. So air will not go inside the socket. The advantage here is that when you sweat in these sockets, it will evaporate through the valve. And it's very lightweight because there are no other parts to it. And the person, when they want to take it off, they press the button here, air will leak, and then just put it off as usual. Main disadvantage, of course, is very sensitive to weight change and volume change. So if they lose weight, they lose suction, and it comes off. This is the same principle used with a liner. Obviously, this is a transtibial level with the transtibial prosthesis here. This is the same silicone as I showed you earlier with the transfemoral level. Grips on the skin, never moves against the skin. Then we have a valve here. So this flange acts like a valve. When you push it into the socket, it looks like an arrow. It points downwards, allows air to escape to the top, but never come back again into the socket. And again, this creates negative pressure, and there'll be a valve at the bottom of the socket. The person will press that valve in order to allow air to escape when they want to take the leg off. Same achieved here, but we have a sleeve on the outside that stops the air going in. So all you have to do always with the suction system is to have a valve, and you want to have a way of stopping air from going in, but allow it to come out of the socket. And these, as I said, allow the least amount of pistoning, but they are very sensitive to change of weight and volume. We like to use them with established amputees, maybe after a few years of amputation. So cosmesis used to be, as I said, the cover on the prosthesis, and in the 90s, the high definition silicons came out to the market. In the 2000s, they were very popular. And you can see on the top here, this person can have even hairs on the cover, and it matches exactly the shape of the appearance of the skin. Problem here is it never matches the color or the tone of the skin, because our skin tone changes with circulation. Even having one hand, if you try it one hand up and one hand down, with your own circulation, you'll find that they are already different color. So going out, walking in the cold or the heat will change my cosmesis completely. My leg will change, of course, and cosmesis will stay as it is, different. Lots of different ways of doing cosmetics. The one on the bottom right here is called the exoskeletal way, where the prosthesis is made out of plastic, and the structure of the prosthesis is from the outside. And this person, if she was wearing longer trousers or a skirt, you wouldn't be able to tell probably that she has an amputation, because the calf here is sculpted to be shaped like the calf here. But this requires a sculpture, not only a prosthetist. In my view, and many people would share this view, is that these days we look at function as the main cosmesis. This person is very proud to have a prosthesis. He's not trying to hide it. He's able to run, and he's actually pulling the look because he's confident. If the person on the other side of the spectrum is not confident, they are shy, they have body image issues, even if you give them a high definition silicone prosthesis like the one here with the hand, they'll still end up hiding their hand in the pocket because it's psychological. It's nothing to do with the leg. So I always say to my patients, it's about function. If you use the arm or leg more functionally, it'll look better to other people anyway. I think we've got probably 2-3 minutes. I'll just go through the feet and knees, and then we'll open for discussion if you wish. So prosthetic feet, when you see a prosthesis, lower limb, most likely is going to have a foot at the bottom. Some of them don't, but most likely it will. And this is one of the early models. When I say early, it was the only one we had before the 80s, maybe. It's called the Satch foot. Satch is a very common acronym, and if you want to remember it in the exam, if you say Satch, even if you get it wrong, at least you knew some prosthetic feet. So Satch means that you have a wooden leg with a shock absorber on the heel. So for heel strike, they have some cushioned heel. And you have a rocker here on the foot to allow them to move with a fixed ankle. Remember, like your Sarmiento cast, when you do that one and you allow people to walk with it, you have to have a rocker at the bottom. The same principle applies to prosthetics. You have to have a rocker to allow for the stiff ankle of the prosthesis. So this used to be very popular. It's still popular nowadays. We can think of it as a low activity foot. It's very lightweight, and it's very nice for, let's say, your elderly chappie who walks very limited distance indoors. So just moving on to the one on the right here. This is called the multi-axial. This was invented in the UK by Blatchford, which is a prosthetic producer here. And this includes a snubber ankle joint. So there's a rubber snubber, which allows some flexibility of the ankle on stance. So only when they are putting the weight on the floor, they can move the ankle in rotation and also in flexion extension. When they lift it off the floor in swing phase, it'll always go back to 90 degrees. So this gives some flexibility on uneven surfaces. Today, also, we think of it as now became comparatively a low activity leg. If you are not sure in the exam, you just say whatever foot you see, say it is a carbon fiber energy storing foot, because these are now 80 to 90% of the market, depending on which center you are going to be at the exam. There are so many designs for these things. The principle is the same. You have a spring, and it absorbs energy and gives you energy back as you move forward. That's why athletes like the springs to be longer. This person has a running leg because it doesn't have a heel. So if it's lacking a heel, or what we call the heel keel, then it becomes a running leg because you're standing on tiptoes, and this person wants to be as tall as possible to be able to have a push. I think I have a video here just to show you how they work. This is from one of the producers in Germany called Orthopaedic, one of the bigger companies. That's their flagship foot called the Tras foot. And the colors just show you the absorption of energy and release back. And if you focus on the ankle, there's also a bit of movement in the ankle joint. So there's a simulated movement. It's not an ankle, but it just moves when the person puts weight on it. So that gives some comfort and very practical, very lightweight. And that's, as I said, the most commonly used type of foot. Recently, 2014, this came to the market. These are hydraulic ankles, allowing you to have slow release of the dorsiflexion. So when the person is in a swing phase, let's say they're moving their leg, they lift it off the floor, and it doesn't go back to 90 degrees exactly like the other feet do. It'll go down slowly, like your kitchen drawer with a push end as they close. And it'll just smoothly go down, which means it is clearing the ground. The toes are not catching the ground, as happens with every amputee. So as a side note, every prosthesis we make in prosthetic centers, we try to make the prosthetic limb slightly shorter than the other side. So we don't match the exact length of the limbs, because amputees do not have dorsiflexion in their ankle, and they catch the toes on the floor if you make it the same length. And that's why these hydraulic ankles became very popular, because they allow the person to spend less energy as they try to lift off the ground. Prosthetic knees. In the exam, you will be wanting, if you can just say this is a free knee or a locked knee, that's you probably pass the exam. So a free knee means that you don't have a lock. So you have a knee that moves flexion extension, and there's no lock to be seen. The locked knees that we have will have a lock on maybe the socket, usually is somewhere approachable or accessible by the patient on the side of the socket on the lateral side. And the locked means that you lock it when you sit down, when you stand up, sorry, so to have the stability. And when the person wants to sit down, they unlock it and they can sit down with it. And these are examples of the free knees that we have. So the market now is exploding with the free knees. And the last thing we have is microprocessor controlled knees. Thank you. So I can see that we have 2 more minutes to go through, and I'm nearly finished here with what I wanted to show you. So when you see a prosthetic leg in the exam, you don't have to know these details about whether it's hydraulic or multi-axial or whatever. You can just say this is a prosthetic knee, and I can see it is locked or unlocked because there's a lock there or there's no lock there. And if it's a locked knee, that means the person is low activity. They probably walk indoors with a frame. If it's not locked, then it is everything else. They could be indoors, they could be outdoors walker. You might, if you see something with a battery, or obviously there's a charger attached to it, it's a microprocessor controlled knee. They are now becoming available on the NHS for the last 2 or 3 years, and you might come across them in the exam. Upper limbs. Very quick note about upper limbs. Very easy one, and I would hate it if you stumble with this one, because technology is not very advanced still, contrary to what you hear on the documentaries. Also, the NHS doesn't provide that much. So you have 2 types always. All the upper limb prostheses, you can say divide them into 2 types: cosmetic or functional. Cosmetic doesn't have any active moving parts, but it does have a lot of passive function. So you can point with it, you can flick a light switch, steady piece of paper, and so on. The functional ones are the ones which have mainly open and close, and they could be either myoelectric with a battery and a motor, or body powered with a cord that works with the shoulders. Usually what we utilize is the scapula being abducted by scapular abduction to open and close the terminal device here. And the differences are many, and you have uses for each one of them. There's no such thing as I want the myoelectric because it's better, because it's fancier. If I was an amputee, for example, I would not use a myoelectric. I would use a body powered, just because I can get the feeling of the hook, and also it's lightweight, and I can fix the problems at home with my own screwdriver without having to come to the center and wait for hours or sometimes days to fix the other one. Right, I think I'll stop here, and I'll open to questions if you wish. I wonder if you actually, any of you has a chance to see any prosthetists or visit any centers during your rotations, because they aren't always available in every hospital that's there.
Thank you, Dr. Sedki. That was a brilliant talk on prosthetics, and I'm sure very useful for those of us who are coming up to the exam. There's no questions in the Q&A box. If anyone's got any, now's the chance to ask.
Of course, the subject is very difficult to teach also on Zoom, because these arms and legs, we used to bring them to the center. We used to carry like several cars will come in loaded with prostheses, and you have to carry them and feel them and stand them to see how they work. Very hard to do it visually like that. But at least if delegates would remember, the name of the prosthesis is the name of the level. So this is a transfemoral prosthesis. It has a socket. There's a terminal device, which is the foot. And there's a prosthetic knee, for example, which is a free knee. You pass the exam. That's all you need to know. Because I suspect the examiners are also orthopedic surgeons who might not be as knowledgeable about the components as others might be.
That's a great little tip there. We've not got any questions, so I think we'll wrap up there. But thank you so much for your time this evening. That was an excellent talk. For those of you who want to learn more, understand more courses up and running, then definitely worth going along.
Thank you. We're looking at the course, so hopefully soon, but I don't know when. They were looking at the end of this year. It doesn't look likely now. Keep you posted.
Fingers crossed. Great. Thanks, everyone.